ప్రమోషన్ శ్రీకాంత్ అంటే మెసేజ్ పెట్టాడు రెగ్యులర్ గా. ఇంకొక 1 minute సార్ చేద్దాం.
అలాగే
ప్రాక్టీస్ గైడ్ లైన్స్ ఫర్ ECT. గుడ్ మార్నింగ్ రమణ ప్రసాద్ సార్. జస్ట్ స్టార్ట్ చేద్దాం సార్. రమణ ప్రసాద్ సార్
చేస్తున్నాను.
మీకు ఇంట్రడక్షన్ చేయట్లేదు సార్, ఎందుకంటే ఎవ్రీబడి నోస్ వాట్ యు ఆర్. ప్రొఫెసర్ ఇన్ గాయత్రి విద్యా పరిషత్ అండ్ మెడికల్ కాలేజ్, అండ్ యూ హ్యావ్ ఎ రిటైర్డ్ ప్రొఫెసర్ ఫ్రమ్ KGH. పర్లేదు. అండ్ very academician, strictly oriented. Even now he does all the procedures, LP, intubation and everything, difficult things with a lot of tension towards the patient. And you will tell communication is very strong, that if he says something he does not know, he will say, I don't know. And when he says, and he is still with the age, he doesn't have any ego feeling. He's still down to earth personality. So thank you very much, sir. Please start.
So kind of you, sir, for your good words. Good morning to all of you. Today my topic is practical guidelines of ECT. Coming to history of ECT, as early as 16th century, induced seizures were used to treat psychiatric conditions. Camphor and metrazole were used to induce seizures. Professor of neuropsychiatry Hugo Cerletti used electrical shocks to produce seizures in animals. Sir, am I audible?
Sir, audible, sir.
The idea to use electrical shock on humans came to Cerletti when he saw how pigs given shock before being butchered to put them in anesthetized state. In 1940s and early 1950s, ECT was given in unmodified form without muscle relaxants. Complications of unmodified ECT, fracture and dislocation of long bones. The use of muscle relaxant to modify the convulsions is named as modified ECT. Electroconvulsive therapy has been used since 1747 AD to cure insanity. It was given with 450 volts direct current, 0.9 amperes per 6 seconds. Aim of ECT is to induce a therapeutic clonic-tonic seizure lasting for at least 15 to 20 seconds. The exact mechanism of action is elusive. ECT may jump-start the brain, helping boost the neurotransmission. Electrical stimulus used in ECT is 800 amperes, Siemens convulsator. The landmark survey by Pippard and Elong, 1981 and 82 in UK, drew attention to the standards in ECT practice. ECT stimulus, sine waveform versus pulse waveform, brief pulse. In a sine wave, there is a continuous stream of electricity, alternating directions and continuously undulating. In brief pulse stimulus, it is a bidirectional, consists of series of rising and falling rectangular pulses of current with adjacent wave with a period of inactivity. So sine wave is continuous undulating form of electricity, whereas brief pulse stimulus is bidirectional rectangular pulses with adjacent periods of inactivity. Duration of each pulse is referred in width in milliseconds. Pulse frequency is defined in terms of pulse pairs per second. Peak current, which is maximum intensity of each pulse, measured from the zero baseline, it is measured in amperes. This photo shows sine wave form. Frequency is measured in pulse pairs per second. Duration in milliseconds. In sine wave form, there is a continuous electricity without periods of breaking. Whereas in brief pulse, there is a rectangular pulse with periods of inactivity. Peak current is from baseline, it is measured from baseline and it is measured in amperes. Frequency is measured in pulse pairs per second and also hertz. Sine wave phase duration is 8.3 milliseconds. Brief pulse measure is duration is 0.5 to 2 milliseconds. Ultra brief is 0.15 to 0.3 milliseconds. Constant voltage versus constant current. Before that, we know what is Ohm's law. Ohm's law is current is inversely proportional to inter-electrode impedance. Constant current is better than constant voltage because constant constant current maintains desirable current throughout the stimulus between electrodes. Stimulus dosimetry. Ergometry is the method to measure the total energy dissipated between two electrodes, and its unit is joule. Most energy is dissipated in the non-CNS organs between electrodes and is highly variable depending upon the impedance. Coulometry is the method to measure the charge that travels their inter-electrode conductor. This is constant across all components, assuming all structures act as a passive but in-series conductor. The unit is coulomb. This is more reliable measure of stimulus dose across brain tissues during ECT. Stimulus choice. Stimulus dose. A stimulus dose which elicits a generalized seizure response is most desirable. The therapeutic potency of ECT can be enhanced by increasing the stimulus well above what may be required for inducing a seizure up to 2 to 3 volts. Determining the threshold. The threshold can be determined by three methods. One is titration method, other is formula method, another is hybrid method. In titration method, one could start from the lowest setting on the machine and re-stimulating in higher steps of 30 to 60 millicures until an adequate seizure occurs. In formula method, each center can determine the predictors and extent of their contribution to seizure threshold and generate a regression equation to yield the threshold stimulus, the formula method. A hybrid procedure is suggested. Begin titration to 2 steps lower than the formula based threshold. This overcomes the repeated and non-convulsive stimuli in the titration procedure. So, two types of ECTs are, one is unilateral and one is bilateral. Unilateral ECT is less potent. Bilateral ECT is recommended in depression if there is urgency for a definitive response, or it was effective in the past without adverse effects. Unilateral ECTs for 2 weeks have been ineffective. Bilateral ECT may also be considered in patients with low risk for cognitive adverse effects, not in extremes of age. When unilateral ECT is practiced, the electrodes are placed on the non-dominant hemisphere. D-ilia position allows greatest inter-electrode distance and has advantage where the cerebral dominance is in doubt. I will tell D-ilia position what is in the coming slides. What are the medications and pre-medications? Neuroleptics must be continued in schizophrenia. Lithium potentiates neuromuscular blocking agents and also worsens the post-ECT disorientation. It is a good practice to withhold lithium before ECT. Antidepressants increase the total number of side effects during ECT course. So they are withheld during ECT and restarted after ECT termination. Benzodiazepines increases the seizure threshold and also shorten seizure duration and interfere with therapeutic efficacy, so they should be given only when mandated. High dose of lorazepam given in catatonics may be referred to ECT. Antagonist flumazenil may be used to facilitate seizure induction. Anticonvulsant, if given for epilepsy, must be continued. Their therapeutic levels preferably maintained at the lower end of therapeutic range. Beta blockers given for cardiac ailments may be continued. If on anti-diabetics, their timing should be monitored to avoid marked hypoglycemia during ECT and recovery. Oral antihypertensives must be allowed even on the morning of ECT with sips of water. Xanthine alkaloids used for asthma can lower threshold and prolong seizures. Their concurrent use is a risk factor and should necessitate EEG monitoring. Chronic use of pseudocholinesterase inhibitor ecothiophyte eye drops may lengthen the suxamethonium effect. Thiopentane 1 to 3 milligrams per kg is standard drug for intravenous. Methoxycetone is preferred for its lesser cardiac adverse effect. Propofol may shorten the seizure duration. Etomidate can increase the seizure duration. It may be preferred in patients with high thresholds. Atropine glycopyrrolate has a protective action on stimulus-induced bradycardia or asystole. The dose of succinylcholine is 0.5 to 1 milligram per kg. Non-depolarizing muscle relaxants are preferred in BISA patients, patients with hyperkalemia, neuroleptic malignant syndrome. The doses of commonly used drugs in ECT, etomidate is 0.2 to 0.6 milligram per kg IV, ketamine 1.5 to 2 milligrams per kg IV, methotrexate 0.75 to 1 milligram per kg, propofol 1 to 1.5 milligram per kg IV, thiopental pentothal sodium 2 to 3 milligrams per kg IV, atropine 0.4 to 1 milligram IV, glycopyrrolate 0.2 to 0.4 milligram IV, succinylcholine 0.5 to 1.25 milligram per kg IV. Atracarium 0.5 milligrams per kg IV. Midazolam 0.5 to 2 milligrams IV. ECT acts as a drug, antipsychotic, antidepressant, anti-manic, mood stabilizer, anti-catatonic. It increases the alpha activity in EEG, anti-epileptic, dopaminergic, decreases dyskinesias. Seizure and physiological monitoring. It is imperative that occurrence of seizure should be confirmed. This poses no problem in unmodified ECT. In modified ECT, masking of peripheral seizures by muscle relaxants necessitate two methods. One is limb isolation technique, another is monitoring with EEG. In limb isolation technique, the forearm is isolated from paralysis by inflating the BP cuff well above the systolic blood pressure just before the injection of succinyl choline. The task force of ECT by American Psychiatric Association has mandated use of EEG monitoring. Automated seizure duration estimation is made by use of computers. Therapeutic seizures have more robust discharges and have more pronounced post-ictal flattening. The electrical stimulus causes bradycardia due to vagal stimulation. Seizure-induced sympathetic outflow soon takes over to cause tachycardia. Cardiovascular effects during ECT have the potential to reflect the therapeutic potency of ECT. In our country and United States of America, ECT is given thrice weekly. In United Kingdom, it is given twice weekly. EEG seizure recorded at threshold stimulus from left to frontal lead. X-axis is time duration. It is 250 milliseconds in a computerized digitalized. Y-axis is amperes. So when the ECT stimulus given, it is polyspike activity. After the seizure, after the stimulation, there is a flattening here. So this is spike activity and flattening. It will allow the estimate the duration of the seizure. The seizure is digitalized at 250 sample seconds. Each division on x-axis corresponds to 2 seconds. On y-axis, it is measured in microvolts. With onset of seizure, there is a progressive building of amplitude with polyspike activity. The seizure progresses more regular with spike and wave activity, 3.5 to 2.5 Hz. The amplitude and frequency drop to abrupt termination of seizure discharge, which helps to time the seizure duration. This is a figure showing where the electrodes are placed in unilateral and bilateral ECT. This diagram shows EEG monitoring, ECG monitoring, and EMG monitoring. Dose titration method. Threshold determination. Start at level indicated by gender and electrode placement. Increase level one step if re-stimulation is necessary. If no adequate seizure has occurred after 3 successive stimulation at the first session, jump to 2 levels for the 4th stimulus. If no adequate seizure has taken place after 4th stimulation, abort the treatment session. Successive treatments after establishing the lower threshold level needed to produce an adequate seizure, increase 3 steps for next treatment with unilateral ECT and 1 step with bilateral ECT. So successive treatment in unilateral ECT, we have to increase by 3 steps, whereas in bilateral only 1 step. Use of ECT, staffing, treatment site and equipment, informed consent, pre-ECT evaluation, treatment procedures, Evaluation of the treatment outcome, documentation. UCT may be used as a primary or secondary treatment. Primary treatment used in depression, acute mania, schizophrenia with psychotic features, catatonia. Secondary treatment, when a patient has shown insufficient improvement with treatment, that is pharmacotherapy, intolerance to medication, deterioration in the condition, appearance of suicidality, pronounced lethargy. Other indications include Parkinson's disease, intractable seizures, neuroleptic malignant syndrome. There is no absolute medical contraindication to use ECT. Risk factors include recent myocardial infarction and intracranial aneurysms, raised ICP, recent cerebral infarction, pulmonary insufficiency, ASA grade 4 and 5 patients. Elderly patient may receive ECT regardless of the age. Pregnant women and nursing mothers may receive ECT during all trimesters of pregnancy, puerperium, and nursing. Children and adolescents should receive ECT when it is evident that other treatments have been ineffective. ECT stimulus first causes parasympathetic stimulation followed by sympathetic stimulation. So brady followed by tachy. It can be safely given in atrial flutter, fibrillation, and all arrhythmic conditions. Before giving ECT, you have to stabilize the condition by the cardiologist. So you can monitor with ECG, X-ray, electrolyte, echo. Beta blockers should be continued. Muscle relaxant may raise concern when giving COPD asthma patients. So what problems you may, laryngospasm you can occur, obstructive sleep apnea, prolonged apnea. These are managed by anticholinergics, positive pressure ventilation, oxygenation, and suction. Central nervous system, hypermetabolic state, hyperperfusion, increased ICP, post-ictal suppression. When do you call a seizure prolonged seizure? When it exceeds more than 3 minutes duration. Non-convulsion status to be watched for in delayed awakening. Safe in slowly growing tumors and metastasis. Transient effects of ECT, disorientation, psychosis, agitation, decreased antegrade and retrograde memory, errors in visuospatial orientation, word finding difficulties. Mechanism of action of ECT, there are several theories proposed. One is anti-convulsant effect by mixed GABAergic activity. Biochemical actions, neurotransmitter and peptidergic systems, increased 5H2 receptors, increased D1 and D3 receptor function. Neurophysiology, increase in global cerebral blood flow, increase in cerebral metabolic rate, increased blood-brain barrier permeability. In the post-ictal period, there is suppression with decreased cerebral blood flow and cerebral metabolic rate. Responders are most likely to exhibit post-ictal suppression and develop slow wave on EEG. Changes are topographically distributed. Medial temporal lobe is involved in anterograde amnesia, and prefrontal cortex in retrograde amnesia. So medial temporal lobe is involved in anterograde amnesia, prefrontal cortex in retrograde amnesia. Neurotransmitter theory. ECT releases hypothalamic or pituitary hormones or both. It releases prolactin, thyroid stimulating hormone ACTH, which results in antidepressant effect. Brain damage theory. Shock damages the brain, causing memory loss and disorientation that creates an illusion that the problems are gone, and a euphoric state, which is frequently observed as a result of temporary brain injury. Neuroendocrine theory. ECT stimulates the diencephalic structures, especially hypothalamus. Cortisol, oxytocin, vasopressin, growth hormone, thyroid hormone, all are increased. Psychological theories, regression hypothesis, fear hypothesis. Regression hypothesis, regression of the behavior to infantile or even prenatal levels induced by the stress involved in the treatment situation or physically induced by convulsion. Fear hypothesis, rather than actual effects of convulsion, which was quickly disqualified after evidences from early studies with sham ECT. Neuroanatomical hypothesis, left sublingual anterior cingulate cortex involved in the modulation of negative mood states, especially depressed mood. There are preliminary relevant findings of increased concentrations of neurotransmitters, dopamine, GABA, glutamate in certain areas of the brain after ECT, resulting in clinical improvement. So, increase in dopamine, increase in GABA, increase in glutamate. ECT increases vagal activity, which may be associated with beneficial effects seen in following ECT. How do you staff? ECT psychiatrist, ECT anesthetist, ECT nurse, recovery nurse. Responsibility of the ECT psychiatrist. Assessing the patient before giving ECT, determining that ECT is indicated. ECT is delivered in accordance with the policies and procedures. Responsibility of the anesthetist, managing the airway, administration of the ultra-brief acting anesthetic and relaxant, monitoring cardiopulmonary function, managing acute adverse effects. Preparation of ECT in pregnancy, pelvic examination, uterine tochodynamimetry, intravenous hydration, administration of non-particulate antacid, wedge under right hip, external fetal cardiac monitoring, equipment for intubation, avoiding excessive hyperventilation. Recovery nurse responsibilities, monitoring vital signs, ECG, mental status, pulse oximetry, administration of intraoperative fluids and oxygen, provision of suctioning, management of post-ictal disorientation and agitation. ECT nurse responsibility, coordinating treatment logistics, checking the proper functioning of the equipment, assessing the shifting of the patient to and from the treatment area, applying stimulus and monitoring electrodes. Treatment site and equipment, area for waiting, treatment, recovery. Treatment area should contain equipment for intubation, seizure induction, that is ECT device, physiological monitoring, including EEG and resuscitation. ECT machine, electrodes, gel, cardiac monitor, bite block or airway, blood pressure machine, suction machine. Medications for ECT, primary anesthetic agent, primary muscle relaxant, anticholinergic agent, medications for management of arrhythmias, hypo or hypertension, medications for management of bronchospasm, status epilepticus, anaphylactic shock, antiemetics, non-narcotic analgesics. Informed consent, provision of adequate information for ECT and ECT procedure, reasons for treatment, expected benefits, foreseeable risks, reasonable alternatives. In case of a minor, consent must be taken from guardian. Pre-ECT evaluation, psychiatric history and mental function evaluation, medical status of the patient, anesthetic evaluation, lab and radiological studies, indicated consultations are obtained, dental examination, dental problems, loose teeth, dentures, and any other general problems. Nil by mouth status minimum of 6 hours before the procedure is mandatory. Treatment procedures, preparation of the patient by removing eyeglass, hearing aids, dentures, jewelry. Initiation of intravenous access, administration of prescribed medication, preparation of the ECT area, checking the equipment, preparation of the scalp electrode area. airway management, assessment of ventilation prior to administration of muscle relaxant, provision of vaccination using positive pressure ventilation and spontaneous respiration regimes, protection of teeth and other oral structures by bite block or airway, supplementary oxygenation in recovery area. The primary goal of stimulus dosing is to produce an adequate seizure, that is called ictal response, with the therapeutic properties that also with minimal adverse cognitive side effects. So there are, in unilateral ECT, there are two electrodes placed, one electrode at the outer margin of the external canthus. A line drawn from the outer margin of the external canthus of the eye to the tragus of the ear. So 50% of this distance, 1 inch above, one electrode is placed here. Outer margin of the external canthus of the eye and tragus of the ear, midpoint 1 inch above. Second electrode is placed, this is nasion and this is inion, midway between this 1 inch below. This point is called D-Ella point. During ECT treatment, motor and EEG seizure monitoring are important. Seizure duration should be monitored to ensure that adequate ictal response occurred, to detect prolonged seizure activity, and to regulate stimulus dosage. Since EEG and motor duration, if seizures are not always equivalent, both should be monitored. EEG monitoring, lead location frontal mastoid placement. EEG monitoring should begin prior to anesthesia, continue till spontaneous respiration resumes. Oximetry should be carried out throughout the procedure to ensure adequate oxygenation. Adverse effect of ECT, cardiovascular effects, prolonged seizure more than 3 minutes, respiratory effects including prolonged apnea, headache, muscle soreness, nausea. Management of ECT seizure. ECT stimulus given, is there an ictal motor response of 15 to 20 seconds? Is there any ictal EEG response? EEG response is more than 25 seconds. So motor seizure of more than 20 seconds, EEG of more than 25 seconds, it is called adequate ictal response. If motor seizure response less than 20 seconds and EEG seizure of less than 25 seconds, it is called missed seizure. So then you have to wait for 20 to 30 seconds and re-stimulate at a higher intensity. Seizure augmentation is by hyperventilation, caffeine, changing anesthetic agent from barbiturate to ketamine. Prolonged seizure. Seizure activity more than 3 minutes. What will you do? Continue ventilation, monitor vital signs, administer midazolam 1 to 2 milligrams IV, wait for 2 minutes, still seizure is there, give second dose of midazolam 1 to 2 milligrams. Seizure still not stopping, give phenytoin sodium 20 milligrams per kg IV. If necessary, intubate, do ABC electrolytes, emergency neurological consultation. Management in the recovery area, management of post-ictal delirium and agitation. Patient should be discharged in the presence of a caretaker. Frequency of treatment is 3 per week. Number of treatments are 6 to 12 for major depression. Recovery, the patient is assessed and monitored. Provide continuous cardiac monitoring, BP for every 15 minutes, continuous SpO2 monitoring, assess loss of consciousness, mini mental examination. Discharge criteria, BP within 20% of the baseline, room air saturation at baseline, following verbal commands, oriented to place, person and time, no postoperative nausea or headache. Once the discharge criteria are met, the patient then transits to the next level of caretaker, inpatient room or outpatient home with a responsible adult. Discharge criteria oriented to time and place and person, tolerating food and drink, no nausea and headache. The evaluation of the treatment outcome, usually within 24 hours of the treatment, ECT should be suspended when mania or hypomania emerges during ECT. Monitoring should include disorientation, antegrade amnesia, emergent mania. Assessment of orientation and memory before ECT treatment and at least weekly throughout the treatment course. If disorientation or memory loss are substantial during the treatment, modification of the ECT procedure, bilateral to right unilateral electrode placement, decrease in electrical intensity, longer intervals may be warranted. So if there is a memory loss of significance, you should change bilateral to unilateral, decrease in electrical intensity, and intervals should be longer. Documentation, ECT assessment or referral note, current mental status, informed consent, laboratory and consultation reports. Thank you so much for patient hearing.
Patient hearing, Raman Prasad, I did not know that ECT had such a big class. So much of information. Please send the PPT to the group.
Sure, sir. Sure.
And very detailed and very nice. I think students should have joined.
Sir, okkati add cheyna sir.
Yes, sure.
Sir, inhalational lo sevoflurane is used whenever there is venous access problem unna, lapte pregnant females lo ECT ivvalanna, because uterine activity ni taggistadi. So tocolytic kuda prophylactic ga ivvachu before you start ECT in pregnant females.
Sure, madam.
Sir, good morning, sir. Ram Prasad, sir. This is Dr. Omkar, sir.
Good morning, Omkar.
Sir, nowadays, preferred drug of choice, sir, for what you call ECT, sir?
Pentothal, scoline.
Sir. And if patient is associated with the history of recent episodes of convulsions and all, appudu kuda scoline ki altama, sir?
Yes, sir.
Sir?
Yes, sir.
Okay, sir. Sir, any experience of using Dexmed in this, sir?
I don't have any.
Okay, sir. Okay. Recently, we had a case, sir, of ECT with history of convulsions. So we went only with thiopental only, sir. So
in the case of history of seizure,
sir,
easy monitoring better.
Sir, inkoti entante methohexital vadevaru, but now thio is used and propofol is also used, sir. And etomidate seizure threshold ni taggistadi, sir. So if we want a prolonged seizure, ante vallu catatonic phase lo unna, lekapothe vallaki mundu nunchi seizures levanukondi, sir. లేకపోతే we want prolonged seizure activity అంటే అప్పుడు etomidate వాడతారు సార్, ఎందుకంటే it decreases the seizure threshold and we can have a prolonged seizure.
I have the experience.
Sir, good morning, sir. Your experience, sir?
I have the experience of giving more than 500 ECTs in the males. We have one day.
Awesome.
Their standard regime is glyco, thiopental, saxa. But we should be careful in recovery room. As like yesterday class, we have to watch for hypoventilation. Supplement oxygen suction should be proper. And in case of vomiting, we should place the patient in lateral position. Sometimes it is find difficulty to bring the agitated patient to the table. We should take help of the it reduces.
Sir, one more thing, sir. Small point to add. Recently, psychiatrist people means if you are using thiopenton, they are like with electroconvulsive therapy, they want to induce some seizure activity in the brain and they want to check. If you are using thio, that activity will be hampered. So they are like there is a study. It seems, sir. One of the psychiatrists told me better use propofol. Any comments on this, sir?
Propofol is itself is anti-epileptic. How it is better than
Anti-emetic, no, sir.
Anti-epileptic.
Even thio has the same property, no, sir.
Hello.
What the dose we use is 1 to 3 milligrams per kg. With that
Yes,
dose,
yes.
it may not have that activity, I think.
Hello.
Yes, madam.
Hi. Morning.
Good morning.
Onkar. Hello.
Good morning, madam.
Morning. Yeah, the same thing. Like I used to do quite a lot of ECT sessions, particularly in winter months in England. You see a lot of depressed people in winter. So we used to have ECT sessions once or twice a week with 10 to 15 patients on a list. So we used to do, and as you said, like ideally we should use pro-convulsant induction agents, because the longer the seizure activity, if it is only for few seconds, we used to give another shock, because they expect at least a minute seizure activity. 30 seconds to minute is good. If it is only 10-15 seconds, they used to say it's too short seizure activity. So we used to give, initially we did have, for many years, we did have methotrexate. That is, that used to be the ideal induction agent, but after a few years, the production of that stopped. So then we started using propofol, because thiopenton is even good anticonvulsant. When propofol first came, we used to think it should not be used in epileptic patients, because that has a little bit of epileptic threshold, seizure threshold. But thiopenton is a good anti-epileptic. So we used to give propofol and small dose of suxamethonium, only like a half dose what we give for intubation, because suxamethonium is only to stop like so to stop like a vigorous movement or breaking the bones, to stop that we give suxamethonium, right? So we used to give like if you don't give propofol, if somebody is allergic to egg protein, because for many years we used to say if somebody is allergic to egg, we should not give. Then we used to give thiopenton or etomidate. Etomidate is also good. It is also pro-convulsant. So this is what we used to do. Thank you.
Madam, use it to limb isolation technique used to follow.
రమణ ప్రసాద్ గారు, మీరు ఒక స్లైడ్ లో చెప్పారు ఏమని 20 seconds కంటే తక్కువ ఈజీ అండ్ 25 seconds కంటే తక్కువ సీజర్ ఉంటే యాక్టివిటీ కాదు, కరెక్ట్ కాదు అని చెప్పారు కదా ఆల్రెడీ.
అవును సార్,
మెన్షన్ చేశారు కదా.
అవును సార్. థెరప్టిక్ యాక్టివిటీ రిలీఫ్ రావాలంటే మినిమం ఆఫ్ 20 seconds బై limb isolation technique and 25 seconds of ఈజీ సీజర్ డ్యూరేషన్ ఉండాలి. మేడం కూడా అదే చెప్పారు కదా సార్.
And we all should know the contraindications very well. There are some contraindications to do ECTs, and we have to exclude those before listing them for ECT, because you can get really very bad arrhythmias or life-risking arrhythmias, or we can get IC bleeds, all those things like in a prone patient. So we have to rule out all the contraindications.
ఇంకోటి ఏంటంటే శ్రీకాకుళం నుంచి విశాఖపట్నం వరకు దేర్ ఇస్ నో ఆర్టీఎంఎస్ మిషన్ లేదు. అంటే రాజమండ్రి వరకు కూడా, ఐ థింక్ విజయవాడలో ఉందేమో తెలియదు. దేర్ ఇస్ నో ఆర్టీఎంఎస్ మిషన్. అంటే కొత్తగా ఈ ఈసీటీ మిషన్స్, దేర్ సో మెనీ ఈసీటీ మిషన్స్ విచ్ యాక్చువల్లీ మోర్ కాంప్లికేషన్. ఆర్టీఎంఎస్ హ్యావ్ ఏ డిఫరెంట్ మెథడ్. ఐ డోంట్ నో వాట్ ఎగ్జాక్ట్లీ ఇట్ ఈస్. So maybe from next month in Vizag, Home Hospital is starting with the RTMS, which actually ECT requires 1, but RTMS requires 5 sessions of it. Even the ECT is 5 to 10,000, but RTMS cost only 2,000. But less complications, no issues, no side effects, and may not require sedation much. So like that, this is a new. I mean, it's not new. It's more than 10 decades. More than 1 decade is there. There are actually Asha hospitals and NIMS hands. Everybody is doing. But in this area from Rajahmundry to Srikakulam, it is not available. So they are starting from next month, this month itself. What is the actually RTMS, Raman Prasad garu?
Not there, sir.
Anybody else? Chandana or Rani madam?
Aren't rapid, sir?
Yeah, RTMS is mission, ECT mission laga. If it is costing, actually ECT mission cost only 5,000 to something like 1 lakh work untundi, and then cost. Whereas RTMS starts from 15 lakhs to 1.5 crore work untundi, like advanced something different. So that only something.
It's magnetic stimulation, sir.
Huh?
It's magnetic stimulation.
RTMS antena?
Yes, sir. Some before those last that's MS is magnetic stimulation.
And that nijangane ekkada
Transcranial magnetic stimulation, I think.
Enti?
Transcranial magnetic stimulation.
Okay. And adi manaki nijanga mission ekkada ee area leda?
లేదు సార్, మన ఇక్కడ లేదు సార్. మేబీ నిమ్హాన్స్ అండ్ నిమ్స్ లోనే ఉన్నట్టుంది.
అంటే మామూలుగా ఈ సిటీ న్యూరో సెంటర్ తర్వాత ఆశా హాస్పిటల్స్ ఇవన్నీ ఉన్నాయి.
I don't know, sir, but నేనైతే ఫ్రీక్వెంట్ గా అయితే మన దగ్గర అయితే వినలేదు ఎప్పుడు కూడా.
అంటే ఇప్పుడు ఈ మంత్ నుంచి స్టార్ట్ చేస్తున్నారు ఇక్కడ హోమ్ హాస్పిటల్.